Okay, we're getting closer to the hour. I've just started recording this, and we will be sharing this video for replay with everyone who registered for our event and posting it on the carp.ca website. And I'm also live streaming it right now on the Carp YouTube channel. If you're just joining us now, welcome. Good morning or good afternoon, wherever you are across the country. If you have a question for our expert today, please do share that question in the chat function at the bottom of your screen in the toolbar. And you can practice that function right now by entering your name, your first name, and letting us know where you're looking in from. I think I've seen someone from every province across the country, and we welcome you all today. I'm working from actually my parents' home, doing a little caregiving today in Oakville, Ontario, and our guest Andy will be joining us from his home office in London, Ontario. Okay, Andy, I'll ask you if you're there to turn on your camera and your microphone again, and we'll get started just in a minute. All right, on the hour. One thing about our members, they tend to be very punctual, so I welcome all of you as you're just logging in now. I'm seeing the numbers click up just over the 300 mark, so welcome to all 300 of you. I'm sure we'll get a little bit more as we get started.
Good.
Andy, you can check your mic one more time?
Yep, can you hear me?
Yeah, perfect. Thank you very much. And how do I sound? All right?
Yep.
And you will be sharing your screen and sharing your slides on your own.
Sure.
Okay.
Do you want to go ahead and do that now?
Yeah, let's see. You put up your starting slide.
Okay, here we go. You see that?
Yeah, it looks great. So we'll give everyone another minute to come on in and welcome everyone who's joining us, perhaps for the first time, to a Carp National webinar. Due to the pandemic, a lot of our chapter events have had to be rescheduled. The events we would host traditionally in Toronto at the Zoomerplex or elsewhere have not been able to take place. So we've found that having these Carp National webinars for our members is a great way for us to continue our interaction with our members, increase engagement, and really hand off some really important educational information on topics that are of interest to our members. So we're glad to present this national webinar to you. And our guest today is Andy Donald. And Andy is the CEO of the Health Depot, Carp's pharmacy partner. And we'll talk a bit more about that relationship later on. And Andy is also a certified geriatric pharmacist with years of experience behind the counter and now in his own digital pharmacy that he can tell you more about. So with that, Andy, I see we're now at 375 participants.
Wow.
We're just past the hour. So with that, welcome to you and over to you to talk about this important issue that our members have brought to us. And in our partnership with the Health Depot, we think we found a great resource for our members in talking about the current state of pharmacy, the role of pharmacists, and what the future holds for older Canadians as we age, and ensuring that their medicines are best suited to them. So Andy, over to you, and perhaps I'll engage you with some questions as they're coming in from our members in the chat, or if something comes across my mind, I'll jump in and ask that question on their behalf.
Sure. I'll do a quick disclaimer for everybody, just because this is the worst time of year for me with my allergies and my asthma. I have both. I take some medications myself for that, and I have this time of year, if I get a little bit of a pant cough, it's not COVID, it's just has to do with my allergies and my asthma at this time of year. When the temperature goes to cold, it shocks my lungs a little bit, but besides that, everything's okay. Yeah, perfect.
Okay, Andy, ready when you are.
Okay, sounds good. All right, well, thanks for having me, Anthony. I really appreciate it. Today's topic is on medication overuse, and a big issue that's been quite out there for quite a long time. My name is Andy Donald, as Anthony mentioned. I've been quite a big advocate in the healthcare space in the background for quite a while. Just a little bit of background on myself. I created a committee at University of Toronto called SOAP, like a bar of soap, Students for Optimizing Advocating Pharmacy Endeavors, just trying to educate people that there's so much more pharmacists can do to help in the healthcare system. I was on the Ontario Pharmacy Association membership committee for a few years. I was an owner of a big pharmacy chain on a lot of committees, trying to really push the envelope that there's so much more pharmacy can do to help out in healthcare, especially in the community, than it's currently happening, and that we need to help out more. And instead of just talking the talk, I decided to walk the walk, and that's kind of why. And this, I do a whole webinar series on empowering your health to help answer any questions and making sure you guys all understand how best to help address some health concerns that you have. So, first of all, to start off, I like to always ask people: are you tired, having trouble sleepy, or are you dizzy all the time? Right? These are often side effects that we get as we age older, as we get to become older adults. And if so, then that might suggest that you're on doses that might be too high, or you might be on too many medications. So there's a couple different, how do I move this? Just a second here, move the banner here. There we go. So there's two main issues of medication issues in older adults that we see. The first is something called non-adherence. You probably heard a lot of that for years. That's been a big focus in pharmacy and medicine and healthcare in general for years, which is non-adherence is not taking medications as prescribed by your doctor. And in Canada, unfortunately, it's less than 50% of Canadians actually take their prescriptions as prescribed by their doctor. So that's a big issue, people not taking medications that they might need. And often, sometimes that is related, believe it or not, because people either decide to take medication, they might forget to take their medication, but also some people are choosing not to take their medications as prescribed by their doctor because of side effects or if it doesn't make them feel well. And that leads into the second point, the other big issue in older adults, which is the issue of being on too many medications. Worldwide, this has got a lot of attention, and starting 2017, 2018, and they refer to it as polypharmacy, which means literally taking 5 or more prescription medications. And it is seen as the other pharmacy's other epidemic before the pandemic, right? Like they don't call it that anymore, but the other one being obviously the opioid crisis. This is the other one, whereas people are taking too many medications worldwide. And I think we want to do a poll here to Anthony. Do you have that? Or
we do, Andy. Now, I just want to ask you a question, just based on point number 2 there. Polypharmacy isn't necessarily a bad thing. That's just the word they use if you have more than 5.
Yes.
But we're going to talk a bit about some of the negative consequences of polypharmacy, as well as what an older adult might do to reconsider what those medications are. So our first poll question, I'm going to launch that right now. And if you see that, we're asking, how many medications are you currently taking? Now, this is an anonymous poll, so do not worry about sharing. We're not going to be looking into how many medications you're taking individually, but we want to know amongst the audience today, how many medications are you currently taking? And that would be different pills, morning, noon, and night. Include your puffers and your what else would there be? There'd be creams and ointments and everything else, or are we talking about just about pills?
Yep. Well, it's like any prescriptions as well.
Any
right?
prescription, yeah.
Inhalers too. Yeah, absolutely.
And we'll give you a minute to look. We got almost 75%
and to
of
go
people.
On that point, you're right. It's become, they're using the word in healthcare in a negative context, the polypharmacy now, because they're using that to refer as the medication overuse problem. But it probably shouldn't be used, because some people, if you have 3 or 4 health conditions, of course you're taking 5 or more prescriptions, right? But it's the general theme is, and we're going to talk to some of the stats and the reasons why this happens, is a lot of people are taking medications sometimes they shouldn't be even on, or the wrong dose of their medications. And that's generally about the issue of medication overuse.
And we're not talking about supplements. A question from Brian. These are just your prescription medications from behind the counter to from your pharmacist. So we'll end the poll there. We've got 85% of the people who participated, and I will share the results. So there's 11% of our members who are currently taking no prescriptions. 64% is the majority with 5 or less, and 21% between 6 and 10. So that's 64 plus 21 are taking 10, between 5 and 10 meds. And then on the higher end, 10 to 15, 3%, and only 1% taking more than 15. So back to you, Andy.
So that shows that a lot of our people here are not taking a lot of meds, so are a lot healthier, which is great. But unfortunately, in 2016, the Canadian Institute of Health Information said that about 2/3 of seniors over the age of 65 are taking 5 or more meds. A quarter of seniors are taking 10 or more medications, and 8.4% of seniors are on 15 or more medications, which is shocking. It's a lot of medications. So we have a lot of healthy individuals here on our talk. But, and the other issues that they mentioned, the same Canadian Institute of Health Information, these are just some stats. Some of them are a little alarming. So the Canadian Institute of Health Information 2016 said 1/3 of all senior hospital visits over the age of 65 are due directly to them taking one potentially inappropriate medication in older adults. And in fact, they also said that 31.1%, almost 1/3 as well, of Canadian seniors are chronically taking one of these unsafe medications every day, chronically. And they refer to these medications, there's something called a Beers list, is a list of medications that are inappropriate. I know what you're thinking. It's not this kind of Beers list, spelled the same way, but it is this Beers list. It's a 21-page document of medications listed that are unsafe to be taken by older adults. The whole issue is here. It doesn't mean you necessarily shouldn't be taking any medications, period, that there's a much safer alternative to treat the same condition that you have than that medication.
Andy, if there's 21 pages, how many different medications would be on those pages approximately?
They often list classes, right? And sometimes, right? And I'm going to go into a couple examples, but there's a lot of different medications. Sometimes they'll list a medication or they'll list a whole class, right?
Yeah.
And I'll get into a couple of those coming up. But there's a lot of medications on this list. And I have a couple examples of some of the more severe ones. But it's shocking that there's this many. And a lot of the issues happen, and jumping ahead on questions, I guess, is because they're safer in younger adults. So sometimes people get on them and they stay on them for years, or sometimes physicians may not know that they're on that list. So it's just not got as much attention what needs to going forward. So why does this occur? Why does medication overuse occur? And why there's such an issue with polypharmacy? Well, the issue is as we get older, medications tend to accumulate in our bodies more and more every year. Because as we age, our ability to process those medications declines, right? Which then leads to more side effects and more toxicity. And the more meds you're on, the more interactions and the more side effects there are, and it just feeds forward. Because what happens is over time, our ability to absorb, getting medications into our body and absorb it into our body, distribute it all over through our bloodstream and into our different organs and our brain and all that, metabolize, which is chopping up the meds once they're in our body, which is usually done in your liver, and then excrete the medications out of our body, which is usually done through our kidneys, are continually changing, right? So a couple examples. These are just few. There's a lot. Like there's blood-brain barrier, but I'm going to go through a couple examples of all those different processes. So absorption. Over time, our stomach acid reduces. So then certain medications and even calcium and iron, our absorption of those change over time. Vitamin B12 changes over time. Our stomach emptying takes a lot longer for us to empty. So certain medications that might have an enteric coat, there's a lot of them out there. Or medications that are very sensitive in acid environments, they change our absorption as well. Our composition of fat and muscle change. So any of those dermal ones, like the patches, injections, subcutaneous, those absorptions will change over time. And even the blood flow to our liver can decrease by up to 40%. And your liver, as I mentioned, is the main place that chops up medications and where all the drug interactions occur in our body.
And Andy, these changes aren't something that someone could say, well, I'm healthy and it doesn't affect me, or I feel just the same as I did when I was in my 40s or whatever. These are naturally occurring across all categories. So as your body is aging, these things are happening to you, regardless of your status of personal health.
Yes, like these are physiological changes that on the average happen. Everyone's different, right? So people might age at different frequencies and stuff like that, but these are the common ones that happen as we age, for sure. And then obviously, if certain things that can damage them, it can accelerate the process, right? But then distribution, like, so that's how we get, the medications around our body. Over time, we get less content of body water in our blood. So that increases certain medications concentrations in our blood. Increase fat deposits as well over time, which then a lot of medications can reservoir then in your body and stick around longer because of that. And then even transport proteins that are meant, a lot of medications, believe it or not, they just don't free float in your blood. They're attached to these little transport molecules like proteins, those change over time. So, but then the main two that are the biggest concern are how we metabolize and excrete the medications. And over time, our liver does slow down, usually every year of our life. And that's what our liver is what chops medications up. So instead of us chopping them up normally and nice and quick, over time it slows down a little bit longer. So then medications stick around a little bit longer. And then if you're taking certain medications, believe it or not, can speed up your liver or slow down your liver even more, right? And there's a lot of different topics on that. Certain medications that can slow down and increase most of your medications levels. But generally over time, your livers do slow down. So then, and more drug-to-drug interactions can occur. And then excreting them from our body, some of it's done from our liver, but the vast majority from our kidneys. And as I'll show in a couple slides, our kidneys significantly reduce every year of our life. And because of that, medications both in the unchanged form, okay, that is not broken down, get excreted from our kidneys, or the metabolites, some of them, like the chopped up portions from the liver, can then stick around longer because of it.
Andy, when we talk to our members about adult vaccinations, for example, we talk about immunosenescence, and there's a natural decline in the body's immune response that just comes with age. And again, these physiological changes are something that I think our participants should know about, that these are happening sort of under the skin. You might not feel them, but they're happening to you, and how your body is processing these medications, that's continuing below your own radar, and it's something that we want to create awareness about.
Absolutely. So generally almost most things in our body do slow down over time. And you're right, you may not notice them. We don't have a lot of receptors. We don't feel our kidneys or our liver slowing down. And damage in your kidneys and liver, you often don't feel until it's really late either, right? So definitely, it's a little bit under the radar. So then the question I pose then is, if our bodies are continually changing, shouldn't our medications be continually changing too? What we see often in the healthcare field is out there, as I come from a big doctor family, I talk about this a little bit more coming up, but you see often that there's an approach in healthcare that if your blood pressure and your blood sugars are fine, and you're taking medications for that, don't rock the boat if those things are off. And you can see people stay on the same dose every year of your life, right? Like for 30, 40 years. But then the issue happens then is if your body's slowing down, that dose isn't staying the same. It's sticking around longer every year of your life. So the obvious answer is yes, they should. Your medication should be changing as your body changes. So getting to this is your kidney function, believe it or not. And this is in your blood work. We can tell just from, it's called serum creatinine and creatinine clearance. Like, get a little too nerdy here, I apologize, but that's in your blood work. Every time you get blood work done, we can see how your kidneys are affected. And that's where most drugs are excreted from your body. And as you can see here, every year of your life, they decrease. These are the on average, male versus female, versus your 20 versus 90, how much your kidneys slow down. And here's a little secret that we're trying to help bring awareness to, is that the pharmaceutical industry, not pharmacy, pharmaceutical industry that patents drugs and gets them out there and whatnot, do most of their medication safety studies in healthy 20 to 40-year-olds, okay? Even if they're meant to treat an 80 to 90-year-old, okay? The reason for this is I had a couple friends in university that paid for some of their university education by doing drug studies, right? And they paid really well. And the reason why they do that is they rightfully so argue in clinical studies that they omit older adults because they don't like people who have other medications or health conditions that could confuse the results of the study. Because then you don't know if the side effects are truly because of that, or this medication, or the combination of the medications. So they rule them out. And the other nice thing that they do is they like to do in younger adults too, is obviously there's less side effects. If you have much better kidney function and liver function, you get less side effects, so it makes the medications look better, right? So they get approved. But the issue then happens, though, is if we're finding out the max tolerated doses for these medications that doctors use to prescribe in healthy young adults, if we apply them to older adults that have less kidney function, and sometimes 3 to 4, less liver function, but sometimes 3 to 4 less kidney function, right? That can cause an issue where medications stick around, side effects, and even toxicity, right?
So Andy, just to make sure I got this right. So when a new medication is brought to market and it's tested, and they're testing the efficacy and the safety and all those things, they're using young, healthy adult population to test the drugs. It gets approved. This is what the drug does. It's very helpful. It goes to market, but it hasn't been tested on seniors with pre-existing conditions. It hasn't been tested on seniors who are taking other medications.
No,
so
because they find that it would be too confusing.
So the prescription, when the doctor writes a prescription, he's writing it based on, or excuse me, his or her knowledge on the recommended dosage for the healthy young adult, or do they write the prescription based on the age and the health of the patient?
Well, often, so when the first drugs often come out, they do phase 4 studies. This is getting a little more into the weeds, that look more into specific age groups down the line. When a meds first comes out, they have the results of the study that shows we see it's safe, tolerated up to this dose for everybody. And we suggest, and the drug company suggests the starting dose and what you want to get up to get the same effect. But that's all done in young, healthy adults, right? The general rule of thumb, this is not like, this is just as a certified geriatric pharmacist, knowing how to personalize meds based on how your body processes it, is we always want to start older adults on much lower doses. Like if you think a regular dose, then halve it or quarter that dose to start and see how you do and go up from there. That's the general theme. So many people get side effects, upset stomach, dizziness and stuff because the doses were started way too high for them. You need to start start low and go slow is what we need to do. We need to educate everyone on that, and physicians as well. It's just the older you are, and depends on your body, we need to personalize it to your body. And if you're having issues with your kidneys or your liver, then for sure we need to go a lot lower.
Yeah. And personalization, I think, is then the key word here, right? That not all medicines are exactly the same for each person, but we can, through your expertise and the doctor's expertise, personalize these drugs.
Yes. And so what works for you may not work for me. I might react to it wrong. So then we have to know how we need to, and that's why the medication overuse is tied, and I'll get more into it as this presentation goes on, to compliance issues, right? People not taking their medications, because if it doesn't make you feel good, a lot of people don't like to take it. And there's so many times throughout the years, patients will share with me that they're not taking their med. They'll take it every 3 days instead of twice a day, but just to keep their doctor happy. But I'm like, you got to let us know, and you got to let us, we can talk to the doctor. If it doesn't make you feel good, we need to switch it to something that does work, because you need the medication for your
and we don't want patients to have half full pill bottles when it's time for renewing their prescription. They should be taking them as prescribed, as directed, but
100%.
We know they're not right now.
And the issue is, that's where the feedback's so key. If it doesn't agree with you, let us know. We need to switch you to something that does agree with you, right? There's a cost to benefit of each medication and side effects to each medication. And it's like a cost benefit ratio. We need to look at that and try to find some that agrees with you, right? That's the issue. So generally, medications stick around a lot longer in your body. And this is often why older adults complain of being dizzy all the time. I was even at a Carp meeting pre-pandemic when we were just starting our idea. And I surveyed the whole room of individuals. They're mostly over 80 and 90. And they all told me that they're on 5 or more meds. And they seem to get dizzier every year of their life. And as they got more meds, they got even dizzier. And then I asked them, how many of you thought that dizziness was a normal process of aging? And everyone lifted up their hand. And I shocked them. I said, well, it's not. Dizziness normally means is not a normal process of aging. Dizziness, confusion, tiredness, and dizziness all the time suggests you might be on doses that are too high for you, or you might be on too many medications. And that kind of floored everyone. A lot of medications cause dizziness. And the combinations of them, so it makes it even worse. So how do we improve this issue of polypharmacy? Like, this is kind of we up until now have discussed what's the problem, right? And why there's so many people on medications. How do we solve this issue, right? Well, that Beers list of the medications, inappropriate medications in older adults that you might have remembered, that Canadians over the age of 65, almost a third, 31.1% of them are in 2016 are actively taking every day one of those inappropriate medications. And a third of all hospital visits are due to them taking one of these medications. Imagine how much healthcare saving we could have in Canada. Our healthcare system's in trouble, and there's lots of cuts happening. Imagine if we could cut out a third of hospital visits for seniors right out of the equation. That's amazing, right? It'd be huge cost savings. They wouldn't have to cut pharmacies, pharmacists, and nurses and doctors as much that they keep happening every year. So now I'm going to go into a couple examples of these medications. As Anthony was alluding to, what are some examples of these meds? Well, there's a couple big classes I'll talk about. There's just so many of them. I can't go through that. It'll be like a 3-hour presentation, right? It'll be a series for me to go through them all. But here's some common side effects that a lot of older adults experience. This is one of the big ones, okay? Drowsiness, blurred vision, dry eye, dry mouth, confusion, constipation, issues with your bladder. It's called urinary incontinence, going to the washroom, dizziness, risk of falls, and reduced REM sleep. Rapid eye movement sleep is dream sleep, okay? I have a whole presentation that we could do potentially later with Carp as well, and sleep that dives into this more. That's the sleep, your exercise sleep for your brain that allows you to consolidate new memories and learning, right? You need to have that dream sleep in order to have that. And if you don't have it, it leads more towards loss of memory and dementia long-term if you deprive your brain of that type of sleep. There's like a deep sleep. I'll just say this real quick. There's a sleep lightning, I call it, right? Where you ricochet back and forth through these different cycles when you sleep. The deep sleep, well, half hour of start of your night, it's like if you have a significant other, you're wondering if they're breathing, you want to poke them with a stick to see if they're still like, are you breathing? That's where your body gets rid of all the toxins, just goes limp. And then your dream sleep is what exercises your brain to make new memories. And you go back and forth throughout those stages throughout the night, but certain medications can rob you of those sleep quality, which then can contribute to worsening of mental state. So all these side effects here come from one single drug class that a lot of different meds come from: diabetic, heart disease, all these kind of things. They're a part of this class of drugs, and they're called anticholinergic drugs, okay? Kind of confusing. Your body uses these signal molecules in your body to contract your muscles all over your body. And your brain is a muscle too, right? So these drugs, if you take too much of them, can block some of those contractions. So it can obviously affect your brain and your other muscles all over your body. And there's a lot, I'm just warning you, there's a lot of anticholinergic drugs out there. And because of that, they've made a scale called an anticholinergic burden scale, right? ACB score, right? Based on how many of these anticholinergic drugs you have can contribute to how much cognitive deficit long-term you can get, right? And it's kind of overwhelming. I had a couple slides and I combined them to one because I didn't want to spend too much time on this, but that chart on the bottom left there is a whole list of drugs that are high anticholinergic score. And there's scores of 1, 2, and 3. The point here is that they say if a score of 3, that third column gets a score of 3. So even if you take one of those drugs, it says that they've attributed that you can have a 1-point drop in your mini mental state exam. That's an exam that people do for cognitive deficits, like they do for Alzheimer's patients over time, to show how much cognitive decline you have over time. You get a 1-point drop in that. It goes up to 30 every 2 years are on one of these medications, right? And I highlighted this little portion at the top here to show you 3 drugs here. I just want to ask everyone, does everyone recognize dimenhydrinate, diphenhydramine, and doxylamine, those 3 drugs? You get a score of 3. They're really bad for you, for your brain, and for your cognition long-term, right? Well, those 3 drugs are Gravol, Benadryl, and Unisome, which is like doxylamine's in a lot of over-the-counter sleep medications, right? They're antihistamines, right? But they're not, if people take them a lot for sleep. I mean, Sleep Easy is Benadryl, it's diphenhydramine. They're meant for allergic reactions, but a lot of older adults take them for sleep because they're available over the counter, but they're not effective for sleep. You can get tolerance to them. The sleep effects of those medications in as little as 3 days to 1 week. The problem is they're extremely anticholinergic, as I mentioned, all those side effects, the dry mouth, the dry eyes, all that kind of stuff. But they really, really lower your dream sleep, okay? And they also increase restless leg syndrome. They're really bad. And so those are ones that get a lot of attention that should definitely not be used for that, only for allergic reactions. And they shouldn't be in over-the-counter medications like this. Like 1 or 2 days here and there, yes, they can give you that sleepy effect, but that's where they need to stop. Another class, benzodiazepines. You probably everyone's heard a little bit about these. They get a lot of attention. They're banned in a lot of long-term care homes now. Diazepam, lorazepam, clonazepam, temazepam. You notice theme here. anything, and in the word Pam, poor Pam. Those are really bad ones. They in the past were used for sleep. They should only ever be used for anxiety, or sometimes if you have a bad seizure disorder, right? So if you have anxiety, you have a dental appointment or an MRI scan, sometimes it can be effective. But the reason is because tolerance develops very, very quickly in 2 to 4 weeks. So you need a higher dose. And they need a higher dose from that to get the same effect. And they're extremely addictive. If you're on them, don't panic. You can come off them. It takes a long time though, right? It can take up to over a year to come off those medications properly. Very, very slow. Working at a pharmacy, working together with the doctor to get you off it. At least minimizing how much of these can be very, very helpful, right? At least going down to the lowest dose possible. Because they do all those effects that we just talked about, like the anticholinergic ones, but they even cause amnesia. You can have blankout for big chunks of the day, to not even remember stuff. Big memory impairment, increased risk of falls because of that too. And it causes even worse issues with your sleep called, I call it alcohol-like drowsiness effect. And so if the good expression on how to explain this is like, the last time we went to a wedding, probably a while ago, right? You got a little silly at the wedding, and instead of 1 to 2 glasses of wine, you had 1 to 2 bottles of wine, okay? So if you went to sleep that night and you went a little overboard with alcohol, you probably felt, even if you slept for 8 or 9 hours, it probably felt like you slept for 3 to 4. The reason for that is you got a very restless sleep. Instead, like as I mentioned before, like some of the other medications, you don't go into your deep sleep as much, which regenerates your cells. You don't go into your dream sleep, you know? So then you get stuck in this little middle sleep. And because of that, you wake up the next day even more like drowsy again. You had a restless night's sleep, and that feeds forward. And that's why these medications, like they definitely like help you sleep for 8 to 9 hours, but it's not a good quality sleep is the issue. And that's why getting off these is a good, nice thing to try, but you don't do it quickly. It's a slow process because they're very, very addictive. Withdrawal effects with them can be severe, right? You can have seizures, muscle spasms. You get insomnia, the opposite effects of what the meds do. Rapid heart rate, nausea. So they can be really, really problematic, right? Other medications to look out for. I'm just going to list a few more. There's so many, guys. Antipsychotic medication should not be used in older adults because they have a black box warning of risk of stroke and death, right? Some of those examples are there's typical and atypical ones. Some of the newer ones that were used for sleep in younger adults should not be used in older adults. Risperidone, quetiapine, and olanzapine, right? Those are very common ones used for sleep, and they help a little bit with mood. But those medications should not be used in older adults unless they're at risk of harming themselves or other people. So they're, again, another medication that you should be switched to a safer alternative. Kidneys, like don't get like the amount of kidney medication you need to slow down. These are all classes. I'm not going to get into them. It's a little overwhelming. That's a slow kidney up on the top left. As it goes down, you need to adjust diabetic medications like even metformin, blood pressure pills, heart medications, antibiotics, all have to be adjusted to your kidneys as they slow down. And a lot of older adults will have kidney function, below 50 and below 30. Those are big thresholds that sometimes you need to come off the medication altogether. They're not safe. Metformin, you should go down to below 50, which a lot of older adults are. You should be down to maximum 1 tablet twice a day, and below 30 mils per minute. This is in your blood work. You should be off it altogether, because they can cause severe problems. And so these are things that are very, very important to constantly monitor and change as we age. So this is just the tip of the iceberg with the issue of the medication overuse, right? Here's a real life example that I hear, unfortunately, all too often in the healthcare industry, right? This is a real life example of how bad it can be. When we started our pharmacy about a couple of years ago, when I left as an owner of a big corporation and started to talk the talk, right? Instead of talk and talk, walk the walk by helping people with this personalizing of meds. One of the marketers here in London was very passionate, wanted to help me out. And he shared this story, right? I've heard a lot of these stories because he was the primary caregiver of his mom, who was a 89 years old, turning 90-year-old, his mom on 17 medications, right? He referred to her as a walking zombie for years. And she had so many different doctors, a lot of different health conditions, went from one doctor to the other. And the doctors would change a dose here, tweak that dose there, add a new medication here, but nothing ever changed, okay? His mom was constantly dizzy and almost falling over all the time. Well, eventually she did fall over and break her head, right? And I was like, oh my God, how's she doing? And he responded to me, oh, she's fine. And I was like, well, how long has it been? Because as you see here, at the age of 90, anyone who breaks their hip, it's like 27.5% of them don't live the next year, right? It's a severe injury that can lead to downward spiraling health. And he goes, oh, it's been over 2 years. In fact, it was the best thing that ever happened to her. I was shocked. And I'm like, what do you mean your mom falling and breaking her hip was the best thing that ever happened to her? Like, that's like, I was like that. It was like, I was just totally perplexed. He says, well, you see, she went to the hospital, the local one here. And in the hospital, she was there for over 2 months, 2 to 3 months. And while there, the doctors worked together, great collaborative care. Doctors worked together with the pharmacists, with blood work and feedback, daily feedback from the nurse. And they personalized her onto the meds that she actually needed, right? And he smiled and said, she went with 17 meds in. How many meds do you think she left on? I think we got another poll. Anthony, do we have that or?
We do.
Perfect. So how many meds do you think she left on? 2 months later, she went into the hospital on 17 medications. This great collaborative care, which is the future of healthcare, in hospital. Pharmacists working together with doctors and feedback from the nurse. How many meds do you think she left on? 2 months later. I got this one. I'll just say that. I'll tell you my answer in a second, and then how many he said.
Well, almost everyone is coming in on 1 to 5 meds. A couple people with none, and a couple people with 6 to 10, and coming in at the bottom, same amount. So we'll end the poll. We'll share the results.
Wow, 83%. So everyone's a little astute. Of course, it's like I think people have figured it was a loaded question, right? Because, but I guess 8 to 9, right? Because I thought half the meds would be amazing, right? And earth-shattering. He said 5. So 12 medications were deprescribed in 2 months. That's an example of healthcare at its finest, right? They figured out that that's all her body needed at that point. So over the years, 12 unnecessary medications had accumulated to the point that she fell down and broke her hip. Healthcare was paying for that, and then had to, she had to go through that scare. And he said it was the best thing that ever happened to his mom because he got his mom back, right? He said that his mom was back to who she was like before, right? Because she was on all those medications that were unnecessary, causing side effects, had accumulated, and the side effects of one drug treated with another drug, treated with another drug, right? In fact, in 2010, in the United States, there was an older adult discontinuation study that found on average, like 12 medications is a lot, okay, to come off. But they found in this discontinuation study for older adults that 4 to 5 medications per person could be stopped. And 88% of those that had that happen reported global improvements in their health. And 2%, only 2% of the drugs that were discontinued had to be restarted, which is just shocking, like to that level, on average, 4 to 5 meds in that study. So that comes the question, like, how did this happen? Like, how are there stories like this? And who's to blame? As I don't want to stress this here, people are quick to point fingers at doctors. I hear this all the time. This is why I'm sharing this. Doctors aren't to blame. I had the unique pleasure of growing up in a big healthcare family.
Sorry, Andy, you froze on me there. And maybe someone in the chat box could tell me if Andy is frozen on their screen as well. Yeah, so Andy's frozen. I'm sure he'll be back shortly. And I wanted to let the audience know that we did hear from a retired physician when we sent out the information for this panel, and we were asking, we were inviting you to join, and he said you're blaming doctors or you're discrediting the physicians, and that's not at all the effort that we're making here. Andy, are you there again? Oh, Andy is logged off, so he'll be back on in a moment. But I wanted to assert to the physician that sent that the retired physician that we are talking more about collaboration, about patients being aware and personalization of medications, and we don't want to in any way discredit the physicians and the doctors, but the role of the pharmacist, I think, is the important point here, and talking to your pharmacist about your medications. So I'm just going to pause myself for a moment and see if I can find Andy. Everyone, please do hold on for a moment. So we're looking for Andy to join us back again. Please hold on. Thank you for your patience. I've just sent another effort at getting him to join back on. Check my email and see if I can find Andy in there. So we're still waiting for Andy to rejoin us. We've lost him. Apologize for the technical issues. I hope to have him coming back in a moment. Great time to refill your coffee cup, and we'll be right back to you. And here comes Andy.
Hey guys, sorry about that. We had a temporary power flicker that disconnected us, and it took a bit for the modem to boot back up. So apologize for that, everyone.
Welcome back. I didn't have much to add to your expertise, so I was trying to track you down. I'm glad you're back.
Okay, thanks. Yeah, I was trying to text you on my phone too, but it finally came back. So I will go back. I apologize for that delay, everyone. I'll go back to this screen share here.
Well, we still got 670 odd people online with us, Andy, so thank you all for staying with us.
Thank you, guys. I apologize for that little brief mishap here. So let me just try to get back here. So I left off that I came from a big doctor family, and that the issue is that doctors are overworked, right? They've been doing their job in what should be an ideal healthcare system's pharmacist job, right? As medications are not their expertise. They need help. So as you see here, our education, both do 4 years of university. Doctors spend 95% of their education on diagnosing and medical procedures, as they should. Those are the most complicated things. There's like 10,000 conditions out there to diagnose you with, right? But they learn 5% about medications, whereas pharmacists do the opposite. And yet, when we get out into the real world, because of lack of information exchange, this has been the issue. It's not doctors' fault that in the healthcare system, when it's pen and paper, there's been no way to share health information about all the diagnosis, blood work, all that kind of stuff. There's been no way for privacy to do that in a safe manner up until now. So doctors have been still left to diagnose, obviously that's the main thing, but select what medication to give you, then monitor the safety of the medication and adjust the doses. And there's a big doctor shortage in Ontario, like it's right across Canada. East Coast is really bad too, where a third of Ontarians don't have a family doctor right now, right? And it's getting worse. My dad's over 70 in a small town. He's from Midland, Ontario, and half the people in Midland don't have a family doctor, and he's not retiring, and a lot of his colleagues have. So, and the other issue is that many community pharmacies are very busy, as I mentioned, and don't have access to important health information to help personalize medications. That's the issue. There's been a disconnect. We call that healthcare siloing, right? In the community setting. Is not allowed to help pharmacists help out in the past, like they can in the hospital. That amazing example of healthcare at its finest, collaboration, you know, unfortunately you have to break your hip or have a stroke to get that kind of collaboration and care in the past to go to the hospital. You have to, Humpty Dumpty has to fall off the wall and break before you try to put them back together. Pharmacists, in order to help out, need access to the diagnosis, which is not on prescriptions, health records, and laboratory work, right? Then an ideal healthcare system going forward, doctors would focus on diagnosing all the health conditions and perform all the procedures, right? Of course. In Ontario, they have pharmacists crossing over to play, do minor ailments prescribing and help out doctors by diagnosing. I think in my mind, I think we should stick to our lane, which is medications, and help out to personalize, be a doctor of your medications, right? And then, so if the doctor diagnoses you with a condition, diabetes, heart disease, you have that unfortunately until the day you die. Pharmacists can be one of the main points then at that point. You still follow up with your doctor every 6 months to a year, obviously, to see if other conditions or if it's progressing. But pharmacists need to help step in to help make sure it's the right medications to control your condition, your symptoms, right? Based on side effects, drug interactions, and how your body processes the medications. That's the ideal. Pharmacists have not had access to that important information up until now, right? But it's now exciting that you can. So Clinical Connect is eHealth, right? It's in all the provinces, most of the provinces, I should say, in a different form. In Ontario, it's called Clinical Connect. This is the network that hospitals share information between doctors and pharmacists and nurses. They have access to this information in the hospital setting, but it's exciting now that this is available in the community setting. And at the Health Depot, we have access to this, and we utilize this with a team of pharmacist specialists. We actually have 3 certified geriatric pharmacists here. My wife is one of them too, to help. We can have access now to this portal that we can see. Oh, it's very tightly regulated, just to make sure everyone's clear. You can only access patients who are your own, right? You cannot access someone who's not your current patient, or they audit you and you're all over the news, right? Health information is very tightly regulated. It took 1.5 years to be approved for this. It's very, very, I'm the privacy officer, the local registration authority. There's a lot of stopgaps you need to do to be able to access the information. But with the diagnosis information, doctor reports, specialist reports, medication history, and blood work in the community setting, as well as the hospital, now pharmacists are able to then make sure that the right medications work together to make sure the right medications for you, to personalize medications. Certified geriatric pharmacists can adapt medications based on our body. We can do it based on your kidney function, liver function, other medications. Unfortunately, this is something that I'm working advocacy long-term on this as well. It's not something that's available, this designation in Canada. You have to do it from the United States, in the United States meds and their units and all that stuff. But I think it's currently not taught in pharmacy school. I see this as the future of pharmacy, in that we need to get this, and I'm working together with some of the schools to get this in their curriculum, because personalizing meds based on blood work and all that kind of stuff is so important going forward. I see this as the future, right? And now that we have this technology, which is amazing, we need to use it, right?
Andy, a couple of questions coming in completely
Sure.
related to that. Can
Sure.
pharmacists request blood tests anywhere in Canada? And can patients see this information themselves?
Different regions, different rules. Yes, like I'm hearing in certain provinces and stuff, pharmacists can. I think in Ontario, technically we still can't. We have to ask the doctor to request it, right? But we tell them why, right? Like, so actually, tell you the truth, to get new blood work done, you have to get the doctor to do it. But I can see the blood work once it's done, right? So I can see all that health information if you're a patient of ours once it's done. So I can see old blood work. But if I want to get a new one, I ask you, I talk to you with you or the caregiver, or it's your doctor, and mention to your doctor, like, it's been a while, the patient's kidney function was this. I need to follow up because they have some medications. We might need to change the doses soon if their kidneys get any worse, right? And I communicate directly on your behalf to the doctor, and then we requisition that, but we keep you in the loop on that 100%, right? So, but then there's other, like certain provinces, the pharmacists can request it themselves. It's changing very quickly. Like we're trying to change our model of pharmacy away from that. Here's a pill, here's a pill, here's a pill, just quick dispensing, right? Red pill, blue pill, white pill, red pill, blue pill, white pill, to one more clinical, right? There's machines coming now that will fill the pill and check the pill, and a registered tech can check the pill too, that pharmacists may not even need to touch a medication going forward. That we need to be clinical, making sure it's the right medication for you, making sure you understand your meds, what you're putting in your body, and the consequences and the benefits of it, right? And that if you're not feeling good with it, there might be better alternatives for you, right? That's the future that I'm really excited about. And I see going forward as being it. Because when you look at this, doctors still, communication between doctors and the community needs to improve as well. And that's, we're getting them on board with this Clinical Connect as well. And then there's other software too. Like there's a lot of committees I'm on in the background. There's something called Prescribe It. The Canadian government funded hundreds of millions of dollars to link all doctor software to all pharmacy software across Canada, the communication piece, which is amazing. So that means if the doctor sends a prescription to the pharmacist, it pops in our software exactly the way the doctor filled it out. And then we can message from our software to the doctor's software if we have a change that we're suggesting, right? And they see it flashing in their software. We say, hey, Dr. So-and-so, we wanted to lower this patient's meds from 50 milligrams to 25 milligrams because their kidney function is this, and it can start to rise and become a little toxic if we don't lower it. And the doctor can then see that and message back, oh, thank you so much, please do that, right? And then we can move forward quick. It's amazing. These kind of technologies are existing. That's one half of the communication piece, and that's right across Canada. 2/3 of pharmacies have that software now. We got about 8,000 to 9,000 doctors and growing. I'm actually the ambassador for Pharmacy for All Canada for Prescribe It, because I really believe that communication tool is very important to make these health teams, these hospital-like health teams. You're texting the doctor like he's right next to you, right? So we're working together like the rounds at the hospital to give good quality care. And so where I see the issue is before we weren't able to do this, but now with the technology, pharmacy as a profession needs to step up. We need to step up to help out with this problem, in that the one person who sees everything, doctors often, they know their medications a little bit more if they're specialists, right? They know the heart medication if you're a heart specialist, but they don't know the other medications, right? So the one person who sees it all, that knows all about the medications, is the pharmacist. Especially, this is why it's important to go to one pharmacy and deal with one team. And it should be on the pharmacy to then communicate between the different doctors and healthcare to make sure it's the right meds for you. Let your cardiologist know that your neurologist has you on this one, and then we might need to switch you to this one because you're on that one, and because your blood, like that's the kind of thing we need to look at, the whole body and everything that's in you to suggest the right alternative, right? To do safety checks. Our profession needs to step up and do that a little bit more with this new technology, which is exciting. And don't get me wrong, it's going to take some time. We're doing that at the Health Depot now, but it's going to take time for this to be coast to coast and right across Canada. And especially some of the, like, for everyone to adapt this. It might take 15, 20 years, but I see this is the future of what pharmacists are going to do. It's amazing. So, and that's what I'm getting at, is like helping to get that great collaborative care you see in the hospital, move our system from a preventative one, where you have to fall and break your hip or to go to the hospital to get that good collaborative care and be there for a while, to preventing, right? To actually help make sure that you don't have these issues and you don't have to fall and break your hip to have like good quality care out in the community, like that personalized touch, personalizing of medications. So pharmacists can help reduce medication overuse by suggesting lower doses, switching to safer alternatives, right, for you, like get you off one of those beers lists onto one that is better for you, or even deprescribing, getting you off a medication that's unnecessary. Because there's a lot of times, sometimes a patient, like one doctor will start a prescription for a medication was really meant for you to take for a couple months. But if another doctor sees it, they may just continue it, thinking it was needed for something else. And sometimes you see patients on medications for years and years and years that they were only meant to be on for a couple months. That as well. It's that specialty that knows the meds needs to be, because that's our specialty, that we need to step up and help out. So, and that's the whole healthcare system needs to switch over to, be allowing pharmacists more billing to allow these kind of changes too, right? It's moving our profession into a more clinical aspect over time. It'll take time, but working together on trying to help prove, obviously, the health benefits of this to try to encourage the government to move more towards a clinical model, right? So yeah, medications need to be personalized to each individual. Like I said, what works for Anthony doesn't necessarily work for me, doesn't work for my wife. But they all need to be personalized to each one of us, and we need to look at the side effects, the drug interactions, and how our body processes those medications to do those properly. So, and then here's on to like what we're trying to do. So this is like, I love this presentation. I'm glad I got to do this one on the national level with Anthony first, because this is the passion reason, this presentation was the passion reason why I started this company, right? The Health Depot Pharmacy, and our slogan is where health comes first. So, and what we've done is trying to build around that idea of personalizing meds, but try to make everything else convenient for you. We bring the pharmacy to you wherever you are. Right now, we're in Ontario. We're going to be expanding to Canada within the year, right across the coast. We're going to have a depot out in BC, one in the prairies, and then one on the East Coast coming up later this year. We provide same-day delivery in southwestern Ontario, next day for over 95% of Ontario, nice and quick. We do it through like, Canada Post, FedEx, a few other shipping companies, right? But we have a whole health store of over 10,000 over-the-counter items and home healthcare products So we do free shipping on all orders of $50 or with your prescription. We have a lot of patients. We have technology. It's on the website. We have a lot of patients who don't have a cell phone or don't have internet. So what we do with them is that we call them, get them on, we take their medication, sync them up together, right? So they're getting them all in one delivery, like to make it a lot easier for them. And we call them 10 days in advance of their delivery and ask them if there's anything else they need. If they need their inhalers or their creams or over-the-counter products. And sometimes they'll say, yeah, put a vitamin D in there for me too, and a pack of Fisherman's Friends or something, right? And we'll add that to their free delivery. We do regular vials and these new, we do regular compliance packs, those big bubble packs, but a new technology is pretty handy are these single dose packs that we put them in organize them for you in date and time. So you don't have to do your pill organizers or anything like that at no extra cost. We ship it to you so you can then tear it off and take it with you wherever you go. Even my dad, who's a full-time physician, right? He wasn't very compliant with his medication. He's got some chronic condition. He's over 70. And he wasn't compliant during because he works full-time as a doctor during the day, unless he took his medication and put them in his top breast pocket. We had to razz him for a little bit and say, you're that doctor who says, do as I say and not as I do. We were razzing him for a little bit but then he started doing that and made it easy because you can take them with wherever you go. Very easy to open. Anyways, you can manage your families if you do have computer, meds all from a portal, see the pictures of the meds, order refills if you want it, or help manage each other's medications with the right permissions. But like I said, a lot of people, we just do automatic refills and we call to help out with that. We can talk to people on online chat, video chat, or on the phone, right? We have a 95-year-old lady who loves to use the online chat, preferably. She says it's a lot easier. I was blown away by that. She's like one of the few people who prefers to type everything to us for their requests. But yeah, you could even be snowbirding down in Florida. And if you had a new inhaler, because I know that their model is more about just volume and not as much care. If you're concerned about a new inhaler or a diabetic device or something, and you're down in Florida, we can set up a video chat and show you how to use it, right to your home. And we combine with a third of Ontarians don't have family doctors. We have virtual doctors that you can see, and so they can prescribe and diagnose you from the comfort of your couch, and then your prescription arrive the same day from the comfort of your couch, right? So really trying to help improve that. And then partnering with Carp, Anthony and company, really trying to help. Really good fit here is advocating better positive change for health. We're also offering better offers. I guess it's like the health, your overall health, but also the health of your wallet. We're trying to help out a bit. So we provide a 20% off first purchase in the health store, 5% off future transactions for all Carp members. And if you're on, like every province will be a little bit different, but a lot of people, like in Ontario, you have a copay for your medications. We lower copays a lot more than a lot of people do. So if you're a high income senior, $611 or $2 in Ontario, if you're low income, we waive that down to $2.99 or $0. So we have a lot of patients that pay $0 and get free delivery. And we have a low dispensing fee if you're not even covered by the government plan. With a lot of private plans or cash payers are, give us a call. The dispensing fee is very, very low compared to a lot of others. It's very low, and we try to help give some of that savings back to you guys. We do a lot of webinars. Like I have an Empowering Your Healthcare that we even offer a website at thehealthdepot.ca. You can sign up for free webinars. They're starting to slow down before the new year. They're going to pick up again on a lot of different topics. It's most popular ones. We're also partnered with older adult centers across Ontario, sleep, how to get a good night's sleep and what medication is going to help and hurt you, pain treatments. COVID-19, I was asked, a lot of the centers are requesting that I did one on COVID-19 because I was involved in a Mass Canada campaign. I'm a little bit of a nerd. I read a lot of journal articles, the science behind it, so you understand that. Vaccinations, and then, even some other topics coming up as well. People can sign up right there, but I'll probably be doing hopefully some more with Carp and Anthony on this platform. And then when it last comes down to it, if you're concerned and wondering if your meds are right for you, call or give me an email right here. We can give a free no obligation consultation or med review just on your medication. I just cannot, unless you're a patient of ours, I cannot look into that health records, right? But I can, based on what you're telling me, I can make some recommendations for sure. And my team can. We're here to help and to help educate and try to problem solve what might be to help everyone get to better health, right? And the idea is,
that's why we're so happy to have the Health Depot as our partner and your expertise. This is the offer to our members. Andy and his team, geriatric pharmacists, can help you go through your medications, and they can help them, get them to you as well if you become one of his patients or clients on the Health Depot list. There's a great offer. There's a discount available for our members because of the relationship we have with the Health Depot. But all of the information you've given us today is the lead up to why we've partnered with you and your group, and your expertise, coming from the other side of the counter when you were running a Shoppers Drug Mart, for example, to now being on the front lines of what really has to change on the side of pharmacy that is patient focused. So please do write that number down, or send Andy an email. Yep. And we'll share this presentation with everyone who has registered, and it'll be posted on our Carp website as well. So you can come back if it was a lot of information in a short hour, look at it again. But please do give Andy a call, send him an email, find out more about the Health Depot and what they can do to help you.
And that's the other thing too, is like all these other health topics. I do on a lot of health topics, is that in our healthcare system, as it becomes a little more overburdened, and as cuts keep on happening, especially in this pandemic when we can't see healthcare people as much, we really need to start to become our own health advocate and really help educating ourselves to be our own kind of, like some individuals say, like, I kind of have to become sometimes your own health pit bull, to know a little bit about your health, to know what you need to raise your voice about, right? And that's where I'm trying to help educate with some of these topics, but also it's important to have these healthcare teams out in the community, right? Like where the pharmacy works together with your doctor, and we come to, it's like those team rounds you see in a hospital. We need to create that in the community, right? Because we all have our own expertise that can help make sure it's the right care and the right therapy for you, right? And that's what it comes down to it. And that's this presentation is the bee's knees of why I started what I did, and why we got to. In a few months I can share. We got a partnership with a large organization that really believes in us disrupting the healthcare space and trying to increase care, that is helping us expand across Canada, which is amazing. To try to trying to make this the new norm and the new expectation for pharmacy going forward, is this extra care, making sure it's not just here's your pill. It's like making sure it's the right medication for you, right? And being accessible always to answer your concerns about your meds, to make sure it is the right one for you, and we can suggest alternatives. Yeah.
And Andy, leave the number up there. And I wanted to ask you a couple of questions that I saw trending through, and one was about medicinal cannabis, THC, CBD. One, two, three. Tell us about what's in the market now, what the possible interactions could be with current meds, and the role of the pharmacist in that.
Yeah. Okay. That's like in my pain talk.
The short version. Yeah.
Yeah. There's like, I might even have to do a whole presentation on cannabis. I really am. Like, I read a lot of journal articles, so I read all the science, and it is going to be game changing, right? Unfortunately, we had a elected official who was a little too eager to just launch as soon as he came into power, cannabis for everybody, right? He just came into power and it's like, legalize it all over without thinking it through. It should involve pharmacy more, and it doesn't right now. And this is why. Cannabis is amazing. I have some stories about that I could share, but I don't know if I have enough time, but maybe for another talk. But about how the stigma needs to be removed. Cannabis is not THC, okay? People think of marijuana, where people get high, is high contents of THC that you don't need. That gets what people high, right? Cannabis doesn't do that. THC in low amounts helps with sleep, helps with pain, helps with a few things, right? For sure. But the cannabinoids and the terpenes in cannabis, very, very helpful for pain killing. Here's a quick question for people. Think about the safest painkiller out there that doctors that's over the counter, that doctors often will recommend you try first if you have some pain. Think about what that is. A lot of you probably are thinking Tylenol, right? Acetaminophen. Well, here's a little tidbit of this. In 2017, 2018, they finally figured out how Tylenol works in our body. I kid you not. Until then, they had no clue. People are like, you take it and it helps the pain, right? That was it. But in 2017, 2018, they figured out that it binds to cannabinoid receptor 1 in your body, in your brain, peripheral system, and in your central system, right? What else do you think binds to cannabinoid receptor 1? Cannabinoids, right? There's 4 cannabinoid receptors, 1, 2, 3, and 4, and cannabis binds to that. And they're just it's exploding the research in this area. People often ask, why is cannabis not covered? Well, it's because you can't really control a lot of the plants, like the constituents. The government's struggling with that. But you'll see in the next few years, because of the explosion of the research in this department, there's going to be a lot more cannabinoid receptor drugs designed that are consistent, that they're going to come out, they're going to cover eventually. Like, it's coming. It's going to help with the opioid epidemic. I've seen seniors that thought they were taking something very illicit. Like, they would scream out, how much time do I have, Anthony? Sarah's story now?
Just we'll come back. Let's promise another talk.
Time. But anyways, the cannabis is very good, but the problem with it, and this is why Europe involves pharmacies, and you need to communicate if you're taking cannabis to your pharmacist and to your doctor. Okay, very important, because it slows down your liver, right? It has a lot of drug interactions. It's like, as I mentioned, your liver chops through your medications. You take cannabis, it slows it down a little bit, which can make medications increase in your body. Not a big issue. We just sometimes have to tweak your medications and often lower those doses a little bit, right? If you're dizzy from it, that's usually because I've had patients that have come in and they thought it was the cannabis, right, that did it, the cannabis oil, right? But it was actually their blood pressure was low and stuff like that. And they had a lot of drug interactions because their meds were sticking around longer. We just had to tweak their doses a bit. That's the one drawback to cannabis, is that, and that's why pharmacy should be involved more, is because it can have an effect on your liver and your other medications, right? So there is a lot of drug interactions, but besides that, it's phenomenal. It's great for pain. And I think down the line, I'll be happy to do a talk just on that and the science behind it. Yeah. But it is definitely going to be game changing to help people off that first epidemic in pharmacy, which is opioid crisis, right? And it's still, don't get me wrong, sometimes you still need opioids for bone pain, cancer pain, things like that, of course. But for the most part, it's like minimizing how much you need at the very least, or you may not even need it if you can get it controlled other ways. And cannabis is a great start. Sure.
And the takeaway for cannabis is talk to your doctor and your pharmacist. You can get it recreationally, you can get it legally now. Let's make sure your medical professionals are working with you on that side as well.
Yeah, it can change everything else, all the other medications in your body. So we just need to know. Yeah.
Another question about medical records.
Yep.
You and your computers allow you to see into people's blood tests. How can a patient look at their own records? Are they able to do that through, if they're a patient of Health Depot?
So no, there's because you're not allowed to share that. We can share the information with you for sure, right? But we can't. There's no viewer. They don't allow that yet. There's some regions and across the other provinces that allow people to see it, right? That has to be allowed and legislated on the government side first, right? So we're allowed to have access to it, but they're very tightly regulated. And we just have to be careful. What they're paranoid and before rolling this out is health breaches, right? If it's a system that shares it with you and somehow that gets breached, everyone's very, very paranoid to make sure it's done in the most safe, encrypted way. And the government has to do that. Like, the system we have to do is very convoluted. It would have to be available to individuals. I see the laws over time changing on that as technology improves, but it's not Ontario-wide yet. Certain regions I hear are starting to launch, I forget if Halton, like certain areas in Ontario are already starting to launch where you can get viewers for your health records, right? For like your recent blood work and this and that. Like, and if you have life labs, like I know some of the companies that actually does blood work, you can access your own blood work there all the time. Right. You can see it. But it's like that whole picture of all your health records. They're not, it might take a little more time, but it's coming. It's coming. In certain provinces, I forget if Alberta, I think Alberta has a lot more visibility to that. But it's coming slowly. They just want to make sure, because it's such a sensitive thing, that if they want to make sure it's not breachable and it's very, very secure for people to be able to access that. So other people can't access yours. Yeah.
And you're up and running fully in Ontario right now, coming before the end of this year to the rest of Canada. Just to reiterate to everyone who's looking in from outside of Ontario, just a reminder on when they can. So can they call this number now, Andy, if they're not in Ontario?
Absolutely. Yep. And we can talk, give you some hints on your medications. Outside of Ontario, I don't have access to those e-health databases yet until we're in those areas and we're approved in those provinces. But if you tell me your medications, I can definitely, let you know which ones you may want to work on. Like, so like I said, like and here's the thing, it's not like shockingly, I was impressed. Sorry, like 12 medications you prescribed in 2.5 months or whatever. That's crazy. That's very fast. But daily blood work and daily, you can do that. Usually you always do one medication at a time and you lower it and then you lower it slowly. You should be going on medications slowly and coming off them slowly. So there's like, sometimes we've gotten patients off like 6 or 7 medications, but you do one at a time, right? You do this one first and make sure you're okay. And then you do this one, right? And yes, like ankle swelling, it's caused by this calcium channel blocker. You don't need and because of that, you don't need this fluid pill, right? And so, you take the one off and then the other. It's a systematic, so you know how you feel, and you got to let your body time to adjust as well. But yeah, I can definitely help out with that, at least point you in the right direction, and our team can. And like at the very least, like, you can talk to your pharmacist and your doctor about that as well.
Yeah, I'll encourage everyone to please take advantage of the offer to get in touch with Andy and the Health Depot. Another question coming in from folks who are also interested in holistic and vitamins, sort of the non-prescribed.
Yes.
How can a pharmacist help with that side of the counter, and what's your impression of the way that those medications work with prescribed medications?
Absolutely. There's a lot. That's a whole nother topic as well. But there's things that if they have a DIN, drug identification number, versus an NPN, natural health product number, right? Those natural health products don't have regulations. So this is tricky, is that they can say what's in the bottles, but not put it in the bottle, right? It's kind of weird. But a lot of the companies that haven't said that don't do that, because then it's bad, like the Webbers and all them out there, because, it'll be bad press. And but it's just, they don't have the same regulations as drug identification numbers have. They have to be tested and trued by Health Canada, right? So they have a lot more tight regulations. And there are over-the-counter items like St. John's wort and certain medications that interact with a lot of your medications. So it's very important to let your pharmacy team know that too, right? Certain medications and things can help, certain ones don't, and they can make it worse. Absolutely. And like, vitamin D, it's crazy important for us. For so many different things, even our respiratory health during this pandemic, right? Because we don't get enough of that during the winter. It acts more like a vitamin, not like a hormone in your body for improving your overall health than an actual vitamin. And a lot of things like that. It's making sure, like minerals, vitamins, minerals that you have. If you take too much of them, they often don't help you. But if you're deficient in them, that's when they can cause problems. So that's why definitely sometimes that can help. And omega-3s, there's a lot of different things. That's a whole nother topic, the do's and don'ts of things that can help you with, but like over-the-counter items do not help you for toe fungus. There's so many different things, like things that can help you or not help you. Like weight loss medications don't work. But those are more, I almost should do another topic on that altogether. There's a lot of holistic things that can help you, but you just have to be careful. Anything you put in your body, and this is the whole point when I help to educate people, there's good and bad to everything. Medications is good and bad. Good and bad might be different for one person to another, right? But there's a consequence to everything you put in your body, and it can interact and muck up some of the other things in your body, right? So that's why we have to look at it as a whole, and telling your pharmacist and your doctor and stuff what over-the-counter and herbal things you're taking is very important too, because you need to look at that all together. Calcium, magnesium, iron, those things bind to certain medications in your stomach. If you take them near the same time, they won't even absorb into your body, right? You need to be careful at what times you're taking certain things with your medication.
Yeah, so I think no matter what you're taking, always good to keep in touch with your pharmacist so that the interactions could be learned on both sides, so the patient knows and that the pharmacist knows what you're taking as well. And the other questions coming in, Andy, about, sorry, just going to pull that up again. Well, there's been so many positive responses here. I think we're going to have a series of these webinars in the future, and it's been very well received. But people asking individual questions about their medicines, and I know we can't answer individuals' queries, but they, if they have a pharmacist right now, they should be asking those questions that you've brought up, but they can call and get in touch with the Health
Yeah.
Depot as well.
We don't want to do individual questions, general questions for sure online, just for people's personal health. I know some people aren't bashful about it. Like I've had patients over the years come and said, Andy, I need my OxyContin, OxyContin, like screaming out that he's on a hard narcotic. Like, and they may not be bashful, but we have to be conscientious of not, like discussing your personal health in front of a lot of other people.
I
But
think
give it a call.
A lot of questions about things on the beers list. They're worried about that,
Yes.
and the interactions and those sleep aids that you brought up in the presentation. So any questions that you have on your specific medications, dosages, interactions, please do get in touch with the Health Depot, and Andy, him and his team of pharmacists can get back to you and hopefully help you maybe reduce some of your medications as well.
Yeah, and I mean, beers list, if you Google beers list, Canadian pharmacist letter and stuff have them. It can be a little overwhelming. There's a lot on them. I'm just warning you.
There was a few requests, and I've shared it in the chat, so it's there as well.
Yeah, perfect. So, but yeah, it's like it's overwhelming how many meds are on these lists and stuff. And sometimes they say a class of drug, and you just have to know that medication is in that class. That like a lot of another example, believe it or not, is stomach acid pills, right? Pantoprazole, rabiprazole, all those ones shouldn't be used for a long period of time. They can cause other issues long term. They're meant for like helping people short term for like stomach acid, or if you're taking an anti-inflammatory drug, which shouldn't be taking long term either. It should be more of a short term thing, because it can cause heart issues and ulcers. There's a lot of things like that. But if you're taking one of those and you have to, and you have no other option, like an anti-inflammatory long term, you need to take a stomach acid drug, or it can cause ulcers and bleeds in your stomach that you may not notice until late. So there's things like that you have to, like, and I said, this is why it's individualized. And even though there's sometimes you might be on a beers list medication, but there might be a very, very legitimate reason why you need to be on it, and other alternatives aren't there. You just have to take that into consideration, and you look at the holistic, make sure that there isn't safer, better alternatives out there. But it's like that old adage, a lot of times people should only be on a stomach acid drug for a month and then come off it. But then people have been on it for like 10 years. Bone pills, even you take bisphosphonates or like alendronate and things like that. You should only be on for a maximum of 5 years to 10 years tops, with holidays in between. Or what can happen is it can cause even fractures in your femur, in your leg, in your hip. If you're taking it too long, you need to go on those bone medication holidays. And believe it or not, even if you stop taking that bone pill, it still is building your bone up for 2 years after you stop taking it. It's such a long-acting drug that things like that, and it's unfortunately so many of these things go unnoticed. Well, our system is very quick to start you on a medication, but no one's trained. Like even in pharmacy, I told you, with blood work and stuff that hasn't been done on how to get you off them, right? And that is something that needs to be very, very targeted. And as we said, because if your kidney function's going down every year of your life, your liver function's going down every year of your life, the meds are accumulating every year of your life, right? And at least the dose has to change or switch to a safer alternative, and eventually even coming off them, right? So that's the take-home message, is we need to start looking on the other side, is if, and that this will massively, if we do this approach, this is what will help with the compliance issue, right? Adherence to medications, is because now we're listening and we're adapting your meds for you, right? People have to believe in that their meds are the best thing for them and that they feel good on it, or they're not going to take them, right? Like, a lot of the conditions like diabetes and heart disease are silent ones, killers kind of thing. That if, you don't realize your blood pressure is skyrocketing and can be bad for your heart, but you don't feel that, you sure as hell feel like it feels like someone's punching your stomach every time you take that pill, right? So, there's another alternative we can give you that doesn't feel like you're being punched in your stomach, right? So That's the issue, right? You shouldn't be in agony to stop that. There's something else that you should be taking that can help out. And that's the targeted, personalized approach for medications that we need to do long-term, right?
Great.
Sure.
Another pharmaceutical issue that Carp is on is adult vaccinations, and we have a webinar coming up. Carp presents, it's the National Vaccine Summit next Thursday, December the 9th. I believe, Andy, you may be sitting on that panel as well. So I'll encourage everyone to look for your invitation to join us for the National Vaccine Summit Part 2 on December the 9th. And we're talking about the importance of vaccinations, including for COVID-19 and other important vaccines like flu shot, the high dose flu for the 65 plus,
Yes.
the pneumococcal vaccines, and for the shingles. So I hope we'll see you on that panel, Andy, and everyone else who's with us today. Please look out for that invitation. So thank you very much to Andy Donald and the Health Depot for your very informative presentation this afternoon, this morning out west. I learned a lot, and your passion for the topic is, I think, it's contagious. And we've had a lot of great feedback, and we hope to have you back on again very soon. So thank you very much, Andy, on behalf of everyone at Carp.
Thanks again. Thanks, Anthony.
Thanks.
It was a pleasure, and look forward to doing more, helping to empower you all in your own health, right? And that's why I do what I do. That's why I became a pharmacist, right? Because I want to help. So
wonderful. Thanks
awesome.
again, everyone. We'll see you soon. All right.
Thanks again.
Bye-bye.
Thanks, Anthony. Thanks, guys.